This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from BMJ Open, published in 2026. It's a retrospective cohort study out of a Chinese tertiary hospital, specifically Beijing Tiantan Hospital, evaluating how we predict mortality in our most vulnerable patients, those in the ICU after a craniotomy.
This is a topic that hits home for anyone covering the neuro ICU. We often see patients who undergo complex craniotomies and then require intensive care for everything from elevated intracranial pressure and impaired consciousness to full-on respiratory failure. As we know, these patients put a significant demand on medical resources.
Exactly. And the authors of this study, led by Jianfeng Zhao and colleagues, point out that accurate prognosis prediction is about more than just numbers. It's about stratified patient management and the optimization of medical resource allocation. They wanted to see which of our standard ICU tools actually works best for the post-craniotomy population.
Right, because we have the general ICU heavy hitters like APACHE II, SAPS II, and SOFA, but then we have our neuro-specific staples like the GCS and the newer GCS-P. Ilara, walk us through the study design and the contenders they looked at.
This was a large-scale, single-center study involving 1,717 adult patients. All of them had undergone a craniotomy and stayed in the ICU for more than 24 hours. The researchers compared 5 scoring systems: APACHE II, SAPS II, the Sequential Organ Failure Assessment, or SOFA, and then the neurological scores, GCS and the GCS pupils, GCS-P.
For the residents listening, let's refresh. GCS-P was introduced by Brennan and colleagues in 2018. It combines the traditional GCS with the pupillary light reflex to enhance its predictive power. The concern has always been that GCS alone doesn't account for things like sepsis or kidney dysfunction, which we see in the ICU.
And that's exactly what this study tested. They used the area under the receiver operating character curve, the AUC, to measure accuracy. In their cohort, the overall in-hospital mortality rate was 6.8%.
That's a significant sample size. What did the head-to-head comparison show for the general population of post-craniotomy patients?
The results were quite telling. SAPS II and APACHE II demonstrated the highest predictive accuracy, with AUCs of 0.822 and 0.819 respectively. They were closely followed by GCS-P at 0.812 and GCS at 0.803. Interestingly, the SOFA score lagged behind with an AUC of 0.762.
So the comprehensive scores, SAPS II and APACHE II, outperformed SOFA significantly. But what strikes me is that GCS and GCS-P weren't far behind. There was no statistically significant difference among SAPS II, APACHE II, GCS, and GCS-P.
That's a key takeaway. Even though GCS and GCS-P don't look at organ systems like the liver or kidneys, they remain remarkably comparable in predictive accuracy to the much more complex SAPS II and APACHE II in this specific surgical population.
Now, as neurosurgeons, we know that post-craniotomy is a broad umbrella. A patient with a supratentorial glioma is very different from someone with an infratentorial lesion or a ruptured aneurysm. Did the study break these down?
They did, and the subgroup analysis is where it gets really interesting for clinical practice. For patients with supratentorial lesions, APACHE II, SAPS II, GCS, and GCS-P all showed similar predictive accuracy, and all of them were superior to SOFA.
But it shifts when we move to the posterior fossa, doesn't it?
It does. For infratentorial lesions, the SOFA score actually outperformed GCS and GCS-P.
That's a nuance we need to pause on. In infratentorial cases, the proximity to the brainstem and the potential for rapid autonomic or systemic decompensation might mean that a score like SOFA, which tracks multi-organ failure, picks up on mortality risks that a simple motor or verbal response doesn't capture as quickly.
Exactly. And then there's the cerebrovascular subgroup, patients with things like intracranial hemorrhages or aneurysms. In that group, SOFA had the lowest predictive accuracy. However, GCS-P, the one that includes the pupillary response, significantly outperformed the standard GCS.
That makes perfect sense clinically. In vascular cases, pupillary changes are often our first and most critical warning sign of herniation or shifting. The fact that the GCS-P reflects that enhanced predictive power confirms what we see at the bedside.
The researchers used the Uden index to find the optimal cutoff values for these scores, which really helps with clinical utility. For instance, they found that if a patient's SAPS II or APACHE II score is above a certain threshold, the risk of in-hospital mortality climbs significantly.
Let's talk about the strengths and limitations here. This was a massive study, 1,717 patients. They used standardized protocols and an a priori power analysis to make sure the sample size was robust.
Right, and they collected comprehensive clinical variables, including lesion localization and surgical complications, which helps mitigate confounding factors. But we have to mention the limitations. It was a retrospective design from a single Chinese tertiary hospital, which means there could be inherent selection bias.
True, and since it's a single-center study, we have to be careful about generalizing these exact AUC values to every ICU worldwide. However, the sheer volume of patients from a high-volume center like Tiantan gives this data a lot of weight.
One of the final points the authors made was that while GCS and GCS-P are excellent because they are quick and neurofocused, they don't capture the systemic complications such as sepsis, liver dysfunction, and kidney dysfunction that can occur in the ICU. Yet despite that, their accuracy for mortality was nearly equal to the more exhaustive APACHE II and SAPS II.
It suggests that in the post-craniotomy world, the neurological status is so dominant in determining the outcome that it often outweighs those other systemic markers, at least in the short term. But if you're looking at a patient with an infratentorial lesion, don't ignore that SOFA score.
Precisely. So to wrap up the findings, for the general post-craniotomy ICU population, APACHE II and SAPS II are your gold standards for predicting in-hospital mortality, but the GCS-P is an incredibly strong, simpler alternative, especially in cerebrovascular cases.
And SOFA, while useful for general critical care, may be less effective overall for these neurosurgical patients, except in those specific infratentorial cases.
It's a great reminder to choose the right tool for the right patient.
Well, that's all the time we have for today's deep dive. A big thank you to the authors of this study for providing some clarity on these scoring systems.
Thanks for listening to the Neurosurgery Hub podcast. We'll link the full BMJ Open paper in the show notes for those who want to look at the specific ROC curves and cutoff values.
Until next time, I'm Dr. Aris.
And I'm Dr. Alara. Stay sharp.